All right, we're live.
All right, good morning, everyone. This is Senate Health and Welfare. It is February 19th, and our agenda today is filled with opportunities to interview folks who have been recommended to us by the governor for appointment to various administrative positions. And we're going to say good morning to Jessica Holmes, who is here looking for reappointment to the Green Mountain Care Board.
Good
And
morning.
Jessica, um, I think you know everyone on the committee. Um, Senator Josh Terenzini from Rutland,
We've not
Hi,
formally
Jessica.
met, but hello, how are you?
Nice to meet you.
Nice to meet you too.
Senator Ruth Hardy from Addison, and Senator Cheryl Hooker from Rutland as well.
Morning,
We're
Jessica.
surrounded by Rutland.
Good morning.
And Senator Cummings cannot be here this morning, so we'll hold the fort. But so thanks for being here. And what would be helpful to us, I think, is for you to give a little bit of your background, your the time that you've spent on the Green Mountain Care Board, and then why you are interested in continuing as a member of the Green Mountain Care Board.
Sure, I'd be happy to do that.
Yeah.
So for the record, my name is Jessica Holmes, and I've been on the Green Mountain Care Board actually since 2014. I was appointed by Governor Shumlin. And I guess it goes back to, my background. I'll give you a little bit about my background. I'm an economist by training. I teach at Middlebury College. I teach economics. I teach microeconomics. I teach economics of social issues. I teach economics of sin. And I teach health economics and policy, and health policy and action is another course I've taught in the past. And so my training actually, my interest in the healthcare sector probably goes back to my undergraduate years. In fact, I almost went and got a PhD in health policy instead of a PhD in economics, but my economics professors were steering me in the direction of economics. So went there, was grounded in the field of economics, but always interested in the healthcare sector. And part of my dissertation was actually involving health. And so I've been teaching, for 20 years, health economics, studying various efforts to reform our healthcare system and try and improve access and improve quality and reduce costs. And when the opening came up in 2014, I thought, well, maybe I can be part of the solution. Maybe I can bring some of my background, my, quantitative background, my economic lens to the problems that we see in our healthcare system. And so I applied, joined the board, and spent the last 6 years on the board. And I think, when it came time for the renewal or the reappointment opportunity, it was a lot of hard thinking because it's a lot to balance all that I do. But it's very impactful work. And I felt like my work wasn't quite done. I felt like there was something still I could add. There were some projects that I'm heavily involved in, particularly around the hospital sustainability efforts in the state. And it felt like I could still add more value, I hoped. And my colleagues at the board asked me to stick around. And I'm not very good at saying no, to be honest with you, which is why I get myself in a lot of situations. So if they felt that I could be of value, and I felt like I could add some more of my perspective to the situation that we are facing in our state right now, I wanted to stay on. So, if I'm on as a state that I love, and if I can be of service, I'm really happy to do it if I can be impactful. So that's a short synopsis of my background. I'm happy to answer deeper questions if anybody has any.
Well, I guess what would be helpful is for you to characterize what the critical issues are coming up or currently at the Green Mountain Care Board that you are interested in solving and participating in decision making about, and then in terms of the regulatory role. So the two things: one, the issues that you're
Sure.
embedded in coming up, and then as you see the regulatory board for the Green Mountain Care Board.
Yeah. Well, I think, from a national perspective, the problems are clear, the issues are clear, right? We spend more per capita on healthcare than any other country. And we're achieving lower outcomes than most other countries. If we look at life expectancy, if we look at infant and maternal mortality rates, if we look at amenable mortality, that's the mortality that could have been prevented. if you'd had timely and appropriate care. There are huge disparities in healthcare along racial and ethnic variables there. And so I think that, when I think about the issues facing Vermont, I think about healthcare not being affordable for many. I think about access not being available to many. And I think about quality concerns that I have. I think that, we need to be reimagining, I think, how we allocate resources in the state, and redirecting money towards more primary care, and redirecting resources towards more care management, and changing how we pay for healthcare so that we're rewarding quality and not volume and quantity. And so some of the biggest critical issues in our state right now are, I think, access issues. I think affordability issues. I think the hospital system, we had half of our hospitals had negative operating margins. This was pre-COVID. Obviously, COVID has impacted the entire system tremendously. They're under a lot of financial stress, under a lot of emotional stress, our providers, in terms of burnout. So where do I think that I can add value? Most of my efforts, I think, since I've been on the board, have been trying to get more data. I'm a quantitative background, I'm an economist, so data is sort of the coin on the realm. So when I first got on the board, we had one data person actually on the board. Now we're up to 4 or 5. And, so there's a greater emphasis on data to drive decision-making. And as we're thinking about the rural hospital concerns that we all have about our hospitals being sustainable, we're trying to gather more data on price variation, more data on cost variation, trying to understand the relationship between price and cost, trying to understand capacity. Is there overutilization? Is there underutilization? Or where are we at with capacity constraints? Excess capacity in some cases, and quality. And so really driving some of those, our decision-making in our hospital budget process, which we have as a regulatory lever. Also the qualified health plans, the rate review process in there, how do we bring more data-driven decision-making there? And certainly as we're renegotiating potentially a new agreement with the federal government that would be helpful towards improving the sustainability of our hospitals, improving health outcomes for Vermonters, reducing costs. I think we have to take some of the lessons we've learned from the all-payer model, part 1, and think about how do we improve that agreement going forward. So I think I can add some historical perspective to what I've seen over the past 6 years, and bring that to the table with our next round of negotiations. So I think, all of these issues have been around for many years. I think I'm optimistic about a lot of things I think we've done. Vermont is on the forefront of healthcare reform. I think the first version of our all-payer model, we learned a lot, and I'm hoping that we can take some of that learning and improve upon it with the next round. So there's a lot of work to be done. And I guess I just don't feel like I can leave unfinished business. So if I can be helpful, I want to be, because the work is not done. The work is not done. Oh, I can't hear you.
Whoops.
Sorry.
No, I was muted. And I missed saying things today, but I want to correct something I said earlier. Today is March 19th, not February 19th. Right. Okay. So yeah, it's fascinating to hear you talk about our potential new waiver, also about value-based payment reform, and what I mean, as you're sitting in a pretty neat position, because you're looking at all the data that's coming in. And can you talk a little bit about your perspective on how, if at all, the Accountable Care Organization is currently influencing change within the system?
Sure. So I think when we think about what is an ACO, right, we think of it's a coalition of providers that are willing to be accountable for cost and quality for a subset of patients. That's sort of the definition of an ACO. So conceptually, the ACO is a vehicle that should allow for provider-driven healthcare reform. And if we think about our ACO, it's largely all of our hospitals, it's a subset of our independent providers, it's our FQHCs, it's the provider network. That's what an ACO is, it's the provider network. And so providers drive the majority of resources in the system. They're the ones making the referrals. They're the ones ordering the tests and the treatments and all of that. If we don't have providers on board for delivery system reform, it's not going to happen. And so the ACO conceptually is an organization that's provider driven. The ACO allows for providers to coordinate efforts without concerns about antitrust, right, concerns. It's the vehicle for payment and delivery reform. It's a centralized vehicle for data collection to make better evidence-based decision-making. And it's a vehicle for care management and in trying to improve care management in the state, which is really important because if you think about it, about 5% of our patient population is responsible for about 50% of expenditures. So really those high-risk individuals are driving a lot of the expenses and incurring a lot of the costs in the system. So if we can really do a better job at care management, then we may be able to improve health quality outcomes for those patients, but also reduce costs. So that's how I think conceptually of the ACO, is that's what it could potentially be, right? This provider-driven reform. Operationally, I think they've struggled. So I think there's been some struggles. I think there's some learnings. I think some of the AHS report is creating some opportunities for some improvements there. I think also, to the degree that we're really trying to move towards more fixed payments, right? Changing how we pay for healthcare. I think Medicare, hopefully my optimism is that in the next agreement, potentially we can actually get true fixed payment in Medicare. And I think that will help achieve scale, the ACO achieve scale, get more hospitals in. You really need scale. You need enough of your patient population in the ACO to change delivery. So you need those more patients in really to see providers change how they're going to deliver care to that patient population. And you need more of the dollars coming in to be in fixed payment, right? Right now, most of the dollars coming in are still fee for service. So the incentives are still aligned for volume and not quality. So until we get more dollars in fixed payment and more patients in the system, delivery reform is going to be slow. But I have optimism. So I tend to be a glass half full person.
Good.
So I have optimism. I just read a headline that maybe our vaccination, some of the technology for the COVID vaccination may be applied to cancer. And I just saw that headline this morning and I'm like, there's cause for optimism. So
there is cause for optimism, right? My glass is always half full,
yeah.
Which can be a problem if it's really half empty. Who knows? But Jessica, as you're talking, you've raised some really important issues, and in terms of actualizing the vision that we've all had for connected care management between hospitals, community service organizations, and obviously you're looking at the data. So what do you see as the most critical events or activities that should happen in order to do what you've been talking about?
Yeah. Well, that's a great question. I think that, when you truly change the payment structure and you truly have the scale, I think you're going to incentivize more hospitals, for example, to have those ties to their community providers, the wraparound services. I think we need more of that. I think we need more integration between medical providers and social service providers. We know that the social determinants of health are really, really important. And they're part of the puzzle of solving better healthcare reform. So I think, I'm encouraged by what I see in hospital budget process. For example, since I came on the board, I have, through the hospital budget process, I've slowly over time been able to see how hospitals are starting to change how they think about the delivery system. So for example, when I first got on the board, I don't think there were any social workers working in emergency rooms. Now we're seeing many more hospitals plant social workers right in their EDs, right? To try and get the patients that are coming in the door that frankly could benefit from wraparound services, getting that service right at the gate. So I think, change is sometimes slow, but I'm seeing some progress there. I'm seeing more communications, at least as described to us through the hospital budget process with their community service providers. I think there's more conversation around population health. I think there's more emphasis on primary care and primary prevention, at least through how the lens through which I've seen it over the 6 years that I've been on the board. Again, glass half full. I think there's more work to be done, but how providers are talking about healthcare seems more expansive now, right? It goes beyond the medical doors of the hospital. So I think that, I don't know if there's, and this is, I'm talking to you all because you may have an ability to emphasize or impact this, but delivery system reform dollars were part of the original agreement, right? And not all of that money materialized. And I think it's important, if we're really truly expecting providers to change how they deliver healthcare, there needs to be investment in that. And I don't know whether some of the funding coming from the federal government could be made available to, help in delivery system reform. The hospitals that are coming out of COVID are financially strapped. Their operating margins are, some of them really deep in the red. And so I don't know whether there might be justification for targeting some of those dollars to help hospitals move towards what they need to be prepared for value-based payment reform, right? Shifting the resources within their walls, changing how they pay their own providers within their networks. That takes an investment. So I think, to really push us over the edge there, we're going to need to have some investments in changing the actual business model of hospitals. So.
Yes, thank you for that. Actually, next week, we're going to be talking a lot about all the things you just talked about. So that'll.
Well, I'll have to listen. That sounds good.
Diving into it. Yeah. So I do want to give others an opportunity to ask questions. And so I see Senator Hardy with her hand up. Senator Hooker has her hand up. I just wanted to make one comment about what we have done in terms of offering a financial stabilization fund for the business of healthcare. I think it's always been kind of the unspoken word that healthcare is a business. Hello. So, but we did put that in place.
Yes.
Last year, and frankly, the American Rescue Plan is something we will be looking at with an eye to how to rescue, because we know it's very dire out there.
Well, I will just to echo what you said. I mean, having heard from the hospitals, they are hugely appreciative, I know, of the state and federal funding that helped them through, last year. Without it, it would have been really abysmal. So
we get it. And we're appreciative that they're appreciative, to tell you the honest truth, because you don't always hear that.
Yeah, no,
we always hear the bad stuff. So, Senator Hardy has a question.
Yeah, thanks, Jessica, for being here. It's good to see you.
Good to see you.
And I guess I want a couple questions. One is pick a little bit at the delivery system reform investments and sort of get more granular about what you specifically mean there. What would help for us to invest money in specifically in that area? And then another question, I'm sure you've seen the letters that are coming out from hospitals asking for sort of an ease up of their budget review process this year. And I'm wondering if you might respond to that and give us your thinking about what the Green Mountain Care Board is doing in that area. And yeah, I don't know. I know you can't speak for the board, but just to hear your thoughts on what you're all thinking. Thanks.
No, I'm happy to. So with respect to the delivery system reform dollars, I don't have the numbers off the top of my head, Senator Hardy, I'm sorry, but when the original contract was signed, there was an opportunity for matching dollars. If the state put up some delivery system reform dollars, then the federal government would match those dollars up to a cap. And we never came anywhere close to the cap. So we didn't, there was in some sense federal money that was left on the table to some degree for delivery system reform. I think that they're probably asking the hospitals what those dollars could have been allocated towards would probably be they'd be a better group to address about how they might have used those dollars. But I think thinking about how hospitals have to change their business models to move away from their, volume-driven business models towards quality-driven business models, how they might invest in services like the social workers and their EDs, behavioral health, mental health, tying in resources from the community. I think that there's a lot social determinants of health. Could those resource dollars have been allocated to try and improve social determinants of health, which we know probably have a higher return of investment than medical care specifically alone? So I think those are the kinds of programmatic, embedding nutritionists in primary care practices, embedding mental health workers in primary care practices, things like that, I think probably would have been great opportunities for delivery system dollars. Does that answer your question somewhat?
Yeah, I think so. And is it, I mean, I guess I know the answer. It's not too late to do that, but in terms of the federal match and the state match from the original agreement, is it at this point where we have to just renegotiate the agreement and start over kind of, or is it still?
Are there some dollars left on the table?
Yeah.
Potentially I'd have to go back, and I think there were some dollars for every year. So that we still have some time left in the agreement. There may still be some dollars on the table.
Okay.
Yeah.
Well, and also remember, we've been given the extension as a result of COVID. So there very well may be dollars on the table. And next week we can ask that question when Ina Backus comes in. So.
Yeah.
Great
okay.
great question for Ina. Okay, so your second question, which I think is a really important one. So yes, there's been some press about the hospital budget process this year. And I think what I would say is that the board has been we had a meeting last week, and we have tried to streamline the hospital budget process this year. We've taken, for example, something that I care deeply about is the quality aspect of our hospital budget process. We call that non-financial reporting. We've actually taken that off the table for the second year in a row to sort of try and eliminate some of that, the burden of trying to accumulate all this data and submit it in. I believe that there have been some other components of the hospital budget process we've tried to streamline for this year with respect to some of the, for example, some of the healthcare advocate questions we are have been eliminated or reduced and pushed to hearing. We are in the process of still deciding what that budget guidance looks like. One of the things that's on the table for consideration is something called, that we're thinking about as presumptive approval. If hospitals meet a couple of parameters around NPR and change in charge, then we would, and again, we haven't voted on this, but it's on the table. We would waive their need to come in for a hearing, which I believe, we hear from hospitals that preparation for the hearing and all the questions and answers that come between the time that they submit the budget and the time they come in for the hearing is onerous. So if they meet some critical thresholds, they would be able to opt for a waived hearing. So that's trying to reduce some of that administrative burden. I think there's been an attempt to try and streamline some of the actual guidance itself. I think there's still some questions on the table that we may pull out of the guidance and put, for example, in the sustainability work that we're also asking hospitals to do, but later in the summer, hopefully post-COVID and all of that. So I think the board is trying to find a workable solution for hospitals that reduces the burden that they have, but also we have a statutory role here to make sure that our hospitals are doing, are financially on track, and that we're trying to ensure that, healthcare is affordable to Vermonters. So we're trying to thread that needle, and we're still in the process of doing that. But the board is very cognizant of the pressures that the hospitals are under with COVID and trying to find a workable solution. One of the things that we're doing is we're not holding hospitals accountable, or not, we're not counting against them any expenses that have related to COVID, right? We feel like, thank goodness they were there and delivering the care that patients needed in terms of testing, in terms of, obviously treating COVID patients, in terms of immunizations. That's off the table for anything that we're looking at. So we're trying our best, I think, to thread that needle, and the decisions haven't been fully made yet. We're still taking public comment. We're still hearing from the hospitals. And we're still trying to come up with a path forward that meets our statutory obligations to, keep track of our hospital budgets, but also recognizes the strains that the hospitals are under.
Yeah.
Good, thank you for that. I'm
Yeah.
gonna shift over to Senator Hooker and know that we'll be spending some time on the questions that are being asked, because this is a key part of moving ahead and ensuring that our healthcare system has some financial stability, but also some quality stability. Yeah. So Senator Hooker, go ahead.
Thank you, Senator. Thank you, Jessica. I'm just curious to know how the data collection is going. Are you finding it easy enough to get the data that you need? And is it specific enough so that you know where problems are and where the good parts are?
Well, the data is we're all on a path here. The data collection is getting better and better, I would say. The data analysis is getting better and better. So we are currently, as part of our hospital rural sustainability efforts, we are looking at prices across hospitals. We're looking at cost differences across hospitals. We're looking at capacity differences across hospitals, and we're looking at quality differences across hospitals. And this is the first real comprehensive look that we've taken, at least in the 6 years that I've been on the board, on all of these dimensions. So this is going to be, I think, a very strong first look at our entire hospital system, to look for opportunities for how we can, reduce costs and improve outcomes for Vermonters by looking at this holistically, this system, and how we can sort of use this data, work with our hospitals, have them respond to the data. The first process is having them validate the data, but then having them respond to the data and help us think about, how do we better prepare for value-based payment, where hospitals and all providers are going to be held accountable for cost and quality. The first thing we need to do is understand cost and quality. So the data collection and data analytics is helping us with that process. And I'm looking forward to when that the data is not fully in yet. We haven't seen it all, but when the data comes in, to be able to look at it, be able to share it with hospitals and other stakeholders to validate that it makes sense, and then use that data to ask some really interesting, important questions about where do we go from here? How do we think about our entire system, and how do we think about a sustainability model that works for Vermonters in this new world that we're going to be entering, value-based payment. One of the pieces of data that we don't often have, and I think it's part of the Green Mountain Care Board has been asking for some more funding, is to basically better track disparities along, in our all payer claims database in terms of race and ethnicity. That data is not currently being collected or not being submitted from the payers. And so I think it would be helpful if we really need to understand and unpack health disparities. That's a data element that we don't currently have. And there are some requests for, I believe, more funding to be able to do that. So that's a piece of data that we don't have, that I think is really important given the health disparities that we're seeing. I think there was a recent article about some of those disparities, even related to COVID, right? The COVID rates among certain subpopulations and the vaccination rates among certain subpopulations. We need to be better at collecting that data so we can understand and address that problem.
You're right. I'm gonna, Senator Hooker, I'm gonna let Senator Terenzini ask a question, because we're starting to go over time and we need to move on to Commissioner Brown. This is just the beginning of a conversation, it sounds like, that is going to take us into some neat places. So Senator, and just FYI, the collection of data based on gender, race, and ethnicity is something that this committee asked for from the Department of Health. So that this was, last year, so it's a start. We need to do more. You're absolutely right. Senator Terenzini, one last question for Jessica Holmes, and then we'll move on.
Thank you, Senator Lyons. Just a sort of a thought as I'm sitting here, Jessica, and maybe it's not in the purview of the Green Mountain Care Board. It probably isn't, but just thinking outside of the box. We hear from hospitals from the Massachusetts border to the Canadian border that they all have problems with recruiting nurses. And is there, because you guys are on the outside looking in, you care for all of the hospitals in Vermont. You don't have a specific horse in the race. Is there a way the Green Mountain Care Board can partner with all of the hospitals in the state to come up with some type of a marketing campaign or strategy to try to recruit nurses to Vermont to help eliminate the burden? Because we also know that it would save money down the road by us not needing to pay the high costs of traveling nurses. So I could see some type of a campaign or strategy from your office to try to help retain and attract new nurses.
Yeah, I mean, I think you raise an incredibly important issue. I think the nursing shortage in our state is only worsening as more of our nurses are retiring and we don't have a pipeline of new nurses coming in. As our population is aging and more of us are going to need chronic care and all of that. I mean, I think the gap is widening and the need for traveling nurses is growing. The board doesn't typically do like media campaigns. We're more of a regulatory body, but we've tried to shine light on this issue. We've had some, and Chair Mullen has actually led the effort here. We've had some panel discussions. We've had some trying to bring in experts to help us come up with some solutions involving, we've had hospital folks on that panel. We've had experts from other states. We've had folks who run the nursing programs in the state, really trying to, how do we unpack this? How do we start to deal with this? And so it's a huge concern. And the way where it manifests for us certainly is in the hospital budget process, as you've said, where the traveling nurse cost, I mean, that's a line item that we see growing. And you're absolutely right. The traveling nurses cost a great deal. So I think some of the areas where there might be opportunity, and I think this is something that probably your committee may have even looked at, is the nursing compact, right? How do we start to make it easier for nurses from other states to be able to practice in Vermont? I have my children are of college age, and I have a friend in town who has a child who's just about to graduate from nursing program in Virginia. And I said, great, hopefully she's coming back, right? We need her. And the answer was no, because she's getting her license in Virginia. And it's cumbersome to get that license in Vermont because Vermont is not part of that nursing compact. If it was part of the nursing compact, she would have come. So it's
guess what? She'll next year, as long as the House accepts the bill that Senator Hardy is reporting on the floor very soon, she'll be able to come to Vermont.
Well, I'm going to tell her parents. That's great.
Yeah, but we passed the bill last year and it got stuck in the House with COVID. So, yeah.
But I do think, there's the things, I think nursing scholarships, I think that, this compact, I think that thinking about our training, how do we create that pipeline? How do we do it in the high schools? Doing it early and setting up people for a career in healthcare. I think there are some solutions. And I believe, that there are some workforce groups that are going to be commencing to start to think about this. So I thank you for the question. It's really an important concern. And we try and do what we can in our part by having some panel discussions and trying to come up with some solutions by listening to experts and think about things, but it's not in our regulatory wheelhouse.
Okay, Jessica, I can't thank you enough for the time that you've given us. It's actually become more than a confirmation hearing, but it really does inform us about you and your work on the board. And the one thing I would like to say is that for the past several years, I at least have been engaged in writing a lot of the legislation that has started the healthcare reform process. And what is really rewarding to hear is how it is operationalizing within the Green Mountain Care Board and other places. So I'm glad that I hear so many negative things from out there in the real world that it's nice to hear some positive comments and thinking about the future. So thank you for that. And we will make our decision about your confirmation and then take our decision to the full Senate probably sometime early next week. So we really appreciate your time and your work.
Well, thank you very much for having me today. I appreciate it, the opportunity.
Terrific. All right, well, take care.
Thank you.
All right. Commissioner Brown, we've been really hard on people this year, so it's been a difficult year. We appreciate all the work that you're doing, and we would like to, we've had a recommendation from the governor that we confirm you as commissioner for the Department of Children and Families. And so this is an opportunity for us to get to know you a little bit more. And so if you don't mind, please introduce yourself for the record and then give us a little bit about your background, the work that you've been engaged in, where I think we're somewhat familiar, but it would be nice to hear from your perspective, the work that you're engaged in within the department and the agency, and then what you see as the critical issues coming up, and why you are interested in continuing as commissioner.
Sure. Well, I really appreciate the committee's time this morning for my considering my confirmation. For the record, my name is Sean Brown. I have devoted almost the entirety of my career to public service, the majority of that in state government. I graduated, I'm from Vermont, come from a family that's been in Vermont before Vermont was a state. So my roots are deep here in Vermont, still have a tremendous amount of family in Vermont. I graduated from the University of Vermont. I've lived in primarily rural areas of Vermont most of my life. I live in the town of Orange with my wife, Tanya, and I have a son who graduated from UVM during COVID last spring and is now at Boston University getting his PhD. And my daughter is a senior in high school doing the dual enrollment last year of high school, first year of college, and is trying to decide where she's going to move on to next to finish her undergraduate work. And so my kids are a little older now. I first started my career in the judiciary way back in 1991. And then I left state government for a brief period and then came back and worked in the Department of Mental Health for several years in the civil commitment and the forensic evaluation unit, and then moved to the Office of Child Support as a district director managing an area of the state in the Northeast Kingdom. Held that role for several years and then moved up into several different leadership positions over the years in the Office of Child Support, and then moved over to a higher level position in the Economic Services Division as an operations director and overseeing operations in certain areas of the state and all of the healthcare eligibility work. Did that role for several years and then was appointed by Governor Shumlin as Deputy Commissioner of the Economic Services Division, administering all of the large economic benefit programs that division administers, and then was reappointed by Governor Scott into that position. During that time, before my appointment as Deputy Commissioner, I participated in the Vermont Leadership Institute in 2014, graduated from that program. Right at the time I was appointed Deputy Commissioner. And then to my surprise, Commissioner Schatz decided to retire in June, and I was inquired if I was interested in this role, and I took some time to think about it with the understanding that this is a job with immense responsibilities, taking care of the welfare of Vermont's children and families, and I, after some consideration and talking with my family and my wife, I felt like, I've been preparing my whole career for a position like this and felt well situated at the time to take this on, although coming on in the middle of a pandemic certainly has its challenges for sure. And we are still in the emergency response, in response to the pandemic, also with an eye towards recovery. And I think that's where, in the next year ahead or so, we need to be focused on making sure Vermonters are able to, move on from the pandemic into the recovery mode, and that we're there to provide and continue to provide the supports and services to make sure that they're getting what they need for their kids to flourish, for the families to flourish, and then, there's that piece of our work just in response to the pandemic. But then when you look at the work of our department, it's broad. We're a large department. We have almost 1,000 employees, about a $500 million budget. We, from our work in the Child Development Division, to the Family Services Division, to the Economic Services Division, to the Office of Child Support, the Office of Economic Opportunity, and the Disability Determination Unit. And Family Services, I think a really important conversation has started regarding Kern-Hatton and kind of, Vermont statutory framework and where there might be gaps in terms of, responses and how we're able to respond to certain circumstances. I think that's incredibly important work to understand if there's improvements we can make in that system. And we're looking forward to that collaborative work with your committee and the Senate Education Committee and the Senate Judiciary Committee. But also there's a couple other areas I think that really meet our attention as well. One area I'm concerned about are our youth who are aging out of the foster care system, and how do we transition them successfully to adulthood, and what supports can we provide, and how do we do that better? I think we need to do better there, and that's one of my assessments now as commissioner. I also believe, on the other end of the system, we need to do more in terms of building out community supports. We still have a large number of children in residential care settings in the state and out of state. And I think it's important that children receive services in the least restrictive and the most supportive setting possible. And I think to do that, we need to enhance, our ability for foster parents to care for a higher level of kids, and make sure that we're making sure the services that those kids and families need are there. To make sure families are able to stay intact if there are concerns, but also when not able to, that kids are staying closer in their communities and they're getting the supports they need in the community. So I think that's all important work that we need to focus on in the Family Services Division. The Economic Services Division, we're doing a lot of great work in response to the pandemic. I'm concerned that when some of the federal funds dry up, that we could be seeing a COVID benefits cliff, and and what are our options and abilities to continue to support Vermont families as we move forward there? What are there creative solutions that can be had? Are there other funding streams? It's going to be critically important. I think homelessness is another area that the pandemic has really shown a spotlight on. And we have a lot of work to do in that area. And I know a lot of attention and energy is happening in the legislature on that issue. And we need to work collaboratively to come up with solutions to increase affordable housing, continue providing subsidies and services to those families. We have seen homelessness grow during the pandemic. The impact of the pandemic has increased, substantially the number of homeless families we're seeing and individuals in Vermont, and it's important we don't lose sight of that. Also, I would say, our work in the Office of Economic Opportunity, particularly around energy, and making sure Vermonters have access to the best technology in terms of weatherization or system replacement, and particularly as our department works on the Climate Council, making sure our work aligns with the goals and the planning that's happening. With that stream of work right now, we have a team of staff participating in that work, but it's important that we collaborate and make sure our work's aligning with that. So there's a lot of, we have a lot going on, and it's important that we maintain the agility to make sure we can continue to focus on all of it at the same time. So.
Thank you. So there's not too much going on, is what I hear. Yeah, no, thank you. So, as you're talking about these different areas, and obviously, I think the foster child, young adult cliff that you talked about is something that we've at least addressed somewhat in the committee. We're trying to. One of our goals would be to look at what's coming to us from the Rescue Act and the dollars that are coming, and what guidelines might be in place. For example, I mean, you were talking about the Economic Services Division benefits cliff that could be coming. Are you familiar with the guidelines at this point that might suggest in that area some funding, some transitional funding process? So that's one question. And then the other question on the foster kids, obviously, is they are not currently allowed to be on their foster parents' health insurance until they're 26, but every other kid can do that. So that's something that I'm very interested in working on. I don't know how much conversation you've had. We can ask Corey Gustafson when he's in, but also then being allowed to go home, because they can't go home. So how do we, so what thinking are you doing in those two areas? One, the foster kids, and two, the economic benefits cliff, and how we might best utilize federal dollars if we can.
Yeah, given we have a new federal administration, I think, once that administration gets its feet on the ground, we anticipate there'll be further changes to some of the programs that we administer. And so, we want to keep an eye to see if there's changes made that will benefit Vermont and Vermonters who rely on those programs as a threshold matter. Also, some of those, like Three Squares Vermont, is 100% federal benefit. And we know that families really, those that are eligible to those that take up, there's a gap there. And so, we need to make sure we're outreaching and making it as easy as possible to obtain and maintain those benefits. And then I think the other issue that I think would support that, which has been really highlighted during the pandemic, is accessing that benefit. And are there, we need to make sure that we have systems in place so that benefits can be used electronically, like through online ordering. I think that would go a long ways to supporting families accessing it. So those are some of the areas we need to focus on, as well as just, and that in itself, I think will broaden the reach of that program. And then also, are there waiver opportunities that might be available that the state can offer? Like we're one of the few states that avails ourselves of the cash out option, where we're able for older Vermonters and disabled Vermonters to pay that benefit in cash, which is a huge benefit in terms of accessing those dollars and the flexibility of using those dollars. Are there other waivers that are available that we might be able to avail ourselves? We recently obtained a waiver to make it much easier for older disabled Vermonters to apply to the program with a more streamlined process that's easier to understand and not as much documentation to fill out. And also that we only need to go through the review process once every 3 years, then instead of once every 12 months. And I think those are the type of opportunities we want to make sure we are fully availing ourselves to make it as easy as possible for folks to stay on the program. Because if there's one piece of information we hear consistently from Vermonters trying to access the program, and from our partners who are assisting Vermonters to try to access the programs, is the federal government certainly hasn't made it easy in terms of its requirements for that program. And so everything we can do to kind of narrow down what information people need to provide and how they provide it goes a long ways in that area. And then in terms of the foster care, I've just started looking at that area a little bit. We received an extra $1 million in what's called Chafee funding from the December stimulus bill, and that is targeted to youth 15 years and older who are aging out of the foster care system. And in looking at how, and working with our partners and our internal team, on how to spend those dollars, I'll be honest with you, I was taken back by, how much little we spend in that area in terms of supporting youth. And also, I feel like we can do a better job just in some of the basics that we do to support that population moving on. Health insurance, accessing benefits, housing is a huge area for those youth as well, whether they're able to return home or not. And we need to be doing more to make sure they're accessing the services and benefits through other providers to make sure that, a youth transitioning out of our care is not ending up in a motel room.
Yeah.
Then we lose them. We need to make
Exactly.
sure they have insurance. We need to make sure they have a license. We need to make sure they have auto. Those are the things we need that we all do for our own kids that set them up to be successful in life and accessing education or other job supports. Those are all things that those kids need, just like every kid needs. And so
I'm going to ask one more question, and then I think the others should be given the opportunity as well. One of the issues that we've heard about recently is the need for DCF counselors, social workers who are in close proximity to their clients, needing vaccination. So if they go visit a home, they're perhaps accompanied by a public safety officer who is vaccinated because they're considered frontline or essential. And so what, if anything, are you doing to protect those folks who are, by virtue of their jobs, required to be in closer proximity to their clients?
Yeah, so we have implemented internal protocols to try to limit, the in-person contact to provide that measure of safety for our staff. The whole conversation surrounding vaccines has certainly been a difficult one. I think we can all acknowledge that.
Yep.
The state's vaccination effort has really been focused on, saving lives. And if you look at the data, it's older Vermonters who are really, at risk of dying from this. And that's led to the age banding. So certainly our staff who fall into those age bands or with health conditions are eligible to get the vaccine. I've talked to our staff many times, and I know this is a very important topic for them. And, we do advocate for our staff, I'll say that. And my hope is given the accelerated vaccination schedule that's happening, I believe our staff will be vaccinated in the next month or so based on the acceleration that's coming for the schedule of vaccinations. And so with the hope that all of our staff, not only family services staff, but we have staff, to be honest with you, who are staffing our district offices in the economic services who are seeing walk-in clients. We've implemented protocols and processes to, for social distancing and mask wearing and sanitizing. But it's a concern across the board, and I'm not, and certainly we advocate for our staff.
Thank you for that. Committee questions for Commissioner Brown, Senator Hardy, and then Senator Terenzini.
Thank you, Commissioner Brown, for being here with us. You clearly have a lot on your plate, describing the purview of the work you do. It's immense. One area that you didn't bring up that is near and dear to my heart is childcare. And there's a lot going on. There's the bill that's coming over to our committee, so I'm sure we're going to be seeing a lot more of you. And one of my concerns is that the perspective from your office doesn't seem as rooted in the reality on the ground as I would like it to be. I don't know how else to describe that. So I'm wondering if you could speak to that, there's a difference between sort of looking at it from the perspective of regulatory, administrative, and versus really what's happening in childcare centers and at the homes of childcare providers and with the families in the childcare realm. And just wanted to hear your thoughts about that and how you think you might, moving forward, get more of that lived experience at your level.
Absolutely, that's a great question, and that is an area of the department that I need to be even more familiar with. I'll be very transparent with you that that's not been my area of expertise prior to this. I want to understand the concerns of providers on the ground, whether it's a center-based or a family-based, so that we're more responsive to their needs. Given where we are in the emergency response, we've done a lot to stabilize the system, and there are more dollars coming to stabilize the system. And I think once we have the time, I really want to be able to focus to understand their needs so that we can have some serious policy conversations and discussions about what can we do better and how do we do that. Because I certainly appreciate the point you're making.
Great. Well, I look forward to working with you on that. So let's make sure that we connect on it. Thank you.
And if you don't connect before, we'll certainly connect when we see the child care bill. No question. Senator Terenzini.
Thanks, Senator Lyons, and good to see you, Commissioner. My couple questions were in regards to adoption and the adoption process with foster kids. I don't pretend to know a lot about it, but I do have some friends who have thought about it and want to, for one reason or another, want to open their homes and their hearts to starting a family by adoption. And the common theme I've heard from a couple different sets of parents is the process is quite cumbersome. It's not all that user friendly. And maybe it's designed that way because it's such a critical and important decision. There's so many lives involved. But is there anything that we could do as a committee or in the Senate to streamline the process or introduce legislation which would make it easier for children to be adopted?
Recently I attended the Vermont Foster Parent Association conference, and this topic came up. And one of the issues that was highlighted in that conversation was that many of our kids come into our care and custody through a child in need of care petition. So we're asking the court to intervene and issue a temporary custody order. And then we assess the case whether it moves forward on a reunification track or maybe some other type of permanency like a termination of parental rights and then an adoption. And absent parents voluntarily relinquished for kids that are on the adoption track, it is a very formalized legal process that takes quite some time to process and play out. Did we lose Senator Terenzini?
Yeah, Commissioner, Senator Terenzini has unpredictable broadband, and which is so unusual in our state. So he will be back. I think, why don't you complete your answer to his question, because this is recorded. And knowing Senator Terenzini, he will make sure he accesses this part of the recording.
Sure. And so given it's a very legal heavy process in terms of there could be a trial, and then the court needs to usually take it under consideration and issue findings. And then many of those determinations are then subsequently appealed to the Vermont Supreme Court. And then that adds a layer of time. It is really a process that is dictated by the legal process. But once that plays out, I believe the adoption process moves a little quicker. And I don't know what we can do given that terminating someone's parental rights is a incredibly fundamental right that you're impacting in some ways, and that there are due process rights. And I think we want to be careful how we approach that. I'm certainly happy to have a conversation. If they're always happy to have a conversation whether improvements can be made to a system or not. But I think we just need to be aware that, terminating someone's parental rights and then placing a child up for adoption is an incredibly serious.
Right. Yeah, we've been engaged in the TPI discussion previously, but the issue is how can it be improved? And here is Senator Terenzini back. So Senator Terenzini, Commissioner Brown did complete his response to your question, but Commissioner Brown, if you don't mind just repeating some of what you said about TPI, termination of parental TPR, termination of parental rights.
Yes,
helpful.
yes. So normally, if
And
we-
I just have to say, I said TPI. I completely apologize. Today I am saying everything wrong. TPR. I
well,
understand.
I certainly can relate to that. Having worked late into the night and got up early this morning to keep working.
Yeah.
So I suspect you're on the same track right now. And yeah, the termination of parental rights, when a child comes into our care and custody, obviously our first goal is always if a child can be reunited or safely stay with their biological family, that's our first goal. If that's not possible after working and providing supports to a family, we could then move to a child on a different permanency goal. Many times that could be termination and then either a placement with a kin or with an adopted family. For that process to happen, if there's not a voluntary relinquishment by both parents, it's a very legal process where there's a trial in the family court, and parents are represented, children are represented, they're appointed a guardian ad litem. So usually they take several days, and then the court takes it under advisement and issues a decision, and then the parties do have an appeal right, and many times when a termination is granted by the court, there's an appeal, and then that process takes time as well. And so during that process, a child might be placed with a home that is interested in adopting that child, and recognizing that they may be eager to adopt that child, but we need to let that legal process run its course, and for its finality to see whether the judicial system supports the termination ultimately. And I think then once that reaches its conclusion, I think the adoption process can happen very quickly. I think probably where is there a way to look at that termination process, and are there improvements that can be made there in that system, but yet protects the rights of parents and as well.
I appreciate that, and I'm sorry that you had to say it twice, and my committee can vouch for me that I have had one heck of a week with internet problems. So thank you, Commissioner, and I look forward to maybe down the road figuring out some of the processes and working together on it.
Terrific. Right. And so, yes, we understand, Senator Terenzini, that you're the only one in the state who has broadband issues. Commissioner Brown, I think this has been a very valuable opportunity for us to hear about your work and the work at DCF. We will be working together on many of the issues that you've brought up, and certainly not the least of which is understanding how to improve perhaps, or what might be improved in the process around the licensure issues that we've heard about through Kern-Hatton. So we look forward to considering a confirmation vote for you, and we'll probably do that fairly quickly or early next week, and then take our recommendation to the full Senate. So thank you, and thank you for being here.
Thank you for the opportunity this morning. I really appreciate it.
All right,
I'll have to say,
terrific.
it's truly an honor to be considered by your committee for confirmation. So thank you.
All right, thank you.
Sure.
All right, so committee, I'm going to ask you, are you okay with going ahead with our next interview? Do you need a 5-minute break?
I'm
not
getting
s-
coffee delivered, so I'm okay.
Oh, oh, you are so lucky.
I have a very nice husband.
Yes, you do. All right. Mine actually made me breakfast around 6 o'clock this morning, so that was good. All right. So we'll keep going. I haven't heard any reason not to. So Corey Gustafson is here, Commissioner of DEVA, Department of Vermont Health Access. Corey, welcome. We're very pleased that you're here. This is our opportunity to interview you for as a confirmation, part of the confirmation process based on the governor's recommendation that we confirm you as commissioner. So if you don't mind, introduce yourself, a little bit about your background, the work that you do, and then the issues that you've been involved in and the critical issues coming up that you're interested in continuing work on. So that sort of gets at the question of why you want to continue as commissioner. So thanks for being here.
Good morning, everyone. Thank you, Chair Lyons. So I guess I'll start by saying, just for the new members, reminding you all that what DEVA is responsible for, and that is we're essentially the backbone of the state's Medicaid program. So when I say backbone, it's the behind the scenes enrollment and eligibility systems, claims processing, enrollment for providers, a lot of the compliance that happens for our Medicaid program. We oversee the policy concerns and considerations in relation to state law and federal policy that comes to us on a regular basis, of course. And so we in Vermont have a few idiosyncrasies about our program, in that we have a very comprehensive 1115 waiver. So it's called the Global Commitment to Health waiver that you've probably heard of. And that waiver gives us the, I guess, authority, you would call it, to essentially run our own public health plan. So in other states, they contract for public health plan services. Our state, we have our single state agency that would be deemed to be AHS, and then DEVA is the entity that is considered the public MCO, although our most recent 1115 update moved us away from that delineation. We're now called a non-risk PIP, stands for it's like prepaid. We get paid by AHS to manage the program. And so the difference of us running a healthcare program is considerable when I'm on national calls. So it's the point of telling you all that is that we have a pretty big responsibility. We also share the responsibility with other departments within AHS, right? So in other budgets, there are Medicaid expenditures, Department of Mental Health, Department of Disability, Aged and Independent Living. They have a significant portion of the Medicaid spend, and we team to provide the best Medicaid program we can. I think that Vermont is often viewed as a leader in terms of the things we've done to provide a more integrated, aligned, and comprehensive coverage for the state's most vulnerable income-wise or are categorically eligible. I'm going to sort of stop there on the, that this is Medicaid, and then I think I'll move in, if it's okay with the committee. If I'm on the right track, I'd go into what we've prioritized. I'm also leaving behind, by the way, in this conversation, knowing you have limited time, we have had a lot of accomplishments. I've been in this position. So this is actually, before we get into the go forward, you did ask me to talk about my background. I feel like I feel like a year in Medicaid is longer than a dog year. And so I don't really remember what I did before I was concerned about what I'm concerned with Medicaid. So at best,
I remember what you used to do. So anytime you want to know, let me
remind me.
know.
I remember. I actually do remember the first confirmation hearing I had where I talked about a long, long time ago. For those that don't know, I was a professional hockey player, and I got a lot of cuts and scars and bruises and injuries, and it felt like the appropriate preface to becoming a Medicaid director. So I know that I come from working in the hospital space as an association representative. I also have worked as a representative for in the insurance industry. So I have this sort of broad background that brought me here to the public space and to public healthcare that I think has served me well for an understanding of the different perspectives. So those are old conversations, but relevant into where what has led me to this place. But I really think of the last 4 years as being quite a significant period of time, and it's really all I think about. So I'm going to move forward on what we're looking into the future at. Does that sound all right to the committee? Okay, so I think we've leveled this before for different committees, and I think I just share it again that our mission is simple. It's providing access to quality healthcare cost efficiently. Our big responsibility is the task of enrolling eligible individuals into their programs. There are, I believe the number is 16 Medicaid eligible groups. So we have, it isn't just a simple, what's your income and you're in kind of thing. It's a very complicated process for different types of categories of eligibility. And then effectively enrolling those members. That has been, our focus and our priority of making sure that we're constantly improving. That's one of our priorities, I should say, is that we're constantly improving what we're doing. I can remind those that have been here and those that haven't been here that I actually probably don't have to remind you. We had some challenges in the ACA rollout back prior to my days here, and we still are dealing with those challenges. We've certainly stabilized the system to the extent that people can get what they want. We continually improve the speed with which we can execute. We track all those numbers. We have scorecards for basically everything we do that impacts effective execution of our responsibilities. But we're always looking for improvement. And in that, like I said, in that enrollment and eligibility space, not just for the members, but for the providers, we've made progress. We look to continue to make progress. That is one of the priorities in the go forward, is to continue on the goal of improvement of the enrollment and eligibility system. It's a very process-based system. There is room for error, user error. I think that the training teams at we have a unit called the enrollment and eligibility. We call it HeyU, and now I'm blanking on the Health Access Enrollment and Eligibility Unit. That's what it's called. That's a rather large unit that came to DVHA from DCF at the time of the ACA rollout. That team has been phenomenal at doing its best with the system that we have, but they have also been very much engaged in this process I'm describing of improving that system over the course of time. So when you hear about the the integrated eligibility and enrollment system improvements, those are fundamental to us doing a better job and using less resources. It's not nothing can be quick. It feels like in this space, because we have to fly the plane while we're building it. So we have to be very, I want to say incremental, but we have to be methodical about it. And, it gets to some of I often talk about with our teams about being patient, persistent, confident, and consistent. And we're trying to be patient yet persistent about this effort. and really about every effort that we are engaging in. And so that you're kind of hearing about that priority of continuous improvement. I use that IT space as an example, but it's all across what we do. We want to improve our professionalization of what we do. Reimbursement is another good example of where we have made really good strides at professionalizing our processes for how we reimburse for services. Of course, there's going to be concerns about how much a provider group, one or another, gets paid, where we welcome those conversations. We have that responsibility, as I said, that that members have access to care, and that care is quality. And so obviously reimbursements have an impact on that. But we also have to be aware. It's not we, it's all of us. I don't mean DVHA. I mean all of us have to be considerate of the revenues available, and how those impact. About a year ago, a little over a year ago, there was the legislature approved combining the state healthcare resource fund with the general fund. So now we're kind of all in the same bucket. That could be a plus or a minus depending on resources available. But we're all in that same sort of space where the general fund really dictates what's available to spend. And so we're constantly navigating that along with finance and management, along with the Senate and and House Appropriations committees. And then of course, at the policy level with your committee and up in the House, on the House side, your colleagues on the House side. So, again, I'm keep rolling past, out into examples of how we really want to professionalize what we're doing. We're looking for consistent improvement in what we do. We're measuring what we do and how it changes our effectiveness. And I think the only priority I've left out, well, I kind of touched on IT, but the only other one I've left out is payment reform. We're really looking to adopt payment that gets the most out of reimbursement. And that means that, I think I've talked about it before in this committee, maybe at BAA, that fee for service as a strategy for reimbursement has some well-documented incentives behind it. You get more if you do more, and not necessarily, and doing more isn't necessarily the path to greatest health and wellness. Is I would say the principle behind our goal of adopting value-based purchasing. A second goal behind that is to set a system of reimbursement that protects both providers and the payers, right? In the fee-for-service world, the lack of predictability of utilization creates winners and losers. In one year, it might be the payer that does better because they don't spend as much on services provided. But when a provider doesn't provide as many services, they're short on what their budgeted amounts were. So, we're trying to smooth those ups and downs through adoption of value-based purchasing. But value-based purchasing isn't just prospective payment either. It is a path to probably our biggest payment reform effort, but we have several others that are really intended to address a certain problem. I think of ABA services. We were really feeling like there was more demand for services than services provided. So we've looked to change how we purchase those services in order to incent providers to take on more clients and customers. And that's an evolving process, but that's one of the ones that has been in place for longer. That isn't just our ACO model, prospective payment, APM model effort. That one's certainly the biggest, but even that one has shown us some positive results over time. It's still in its infancy, but those are two examples of where we really want to adopt more value-based purchasing. I'll give you one last reason that it's a priority of ours. It's a priority of the federal government. They have said they want to move to more value-based purchasing, and our providers that we are one of their payers, are very much paying attention to what Medicare is doing. The other really large payer in the state that kind of defines what's happening as far as providers go. So if the federal government continues to move in that direction, we are on the leading edge, I will say, and as we are often in this state, we are on the leading edge in that space. And at this point, it appears that continuing down that path is a priority of the federal government. So it continues to be a priority of ours. So just to recap, adoption of value-based payments, management of IT projects, and operational performance improvement are our three priorities related to our responsibilities, again, of enrolling members, paying for care, and promoting health. Well, that's the overview of where, strategically where we want to go and where our focus lies. And then there's all the things that come at us unexpectedly that we need to deal with on a day-to-day basis. And I kind of will leave it there, maybe except to say, for example, Congress just passed a bill that laid quite a bit of effort at our feet. I mean, DVHA, and I mean, as far as our other responsibility, I just talked about Medicaid. I didn't talk about our relationship to the qualified health plans and the exchange. The ARP, that's the rescue plan, American Rescue Plan, that was passed a week ago, 2 weeks ago. No, a week ago, right? There's Medicaid years for you. It was a week ago, but it feels like a month ago. That plan offers greater subsidies to Americans who purchase qualified health plans. We will need to do information technology upgrade. It's not upgrades, but we will need to make changes in our systems to accommodate that. And with a system that isn't flexible to the extent it should be, a system that relies on process, we're right now gauging what the level of effort is, how fast we can get it done, and how we will do it while we're flying the plane, and how does it fit in with the IE&E projects? How does it fit in with premium processing, which is a project that's been in the works for a long time. It got stopped up by COVID a year ago, and we need to get that done. We need to continue on IE&E because our federal partners need to get it done, and then now we need to fit in this American Rescue Plan, these changes into our work streams, and so that's an indication. I think, to answer your question long-windedly, I admit, but there's no other way to do it than to say everything that we have in front of us to answer your question. What's in front of us?
Thank you. That's great. And just so you know, we're going to have Ina Backus in next week, and be maybe talking a little bit about some of the areas that you've touched on for payment reform. So, and we will have you or maybe Nissa back in to talk about next steps. Looking forward to that work.
Yep.
Actually,
and I think are you talking about ARP, or are you talking about generally?
Generally,
yeah.
and could be ARP. So yes,
yeah,
both. So
yeah, and we haven't had a budget conversation with this committee either, have we?
No.
The proposed budget.
But you
when
will.
it comes over. Yeah, we will. I've been into I was in Senate appropriations, and I was realizing before I came on that we have not had a conversation, this budget conversation, which really kind of goes over what's happened in the last year, and of course what's in our budget, but it would have been great as a precursor to a confirmation hearing, because you'd have a real sense of here's what happened over the last year, which of course, if you've heard from any other departments, a lot has happened. Of course, dealing and responding to the pandemic, as far as we've done a lot in the space of reducing burdens on providers, as well as opening the door to telehealth. By the way, thank you to this committee for your consideration of some of our concerns on the audio only in the go forward. That I appreciate that. That's work well done. I just want to commend you and thank you. And so you have actually a digital copy of our annual report, which includes our budget, but we'll be in to talk about that. But I just want to
We
acknowledge
won't,
more of a sense of
actually, we won't hold up your confirmation hearing for that, for your report on the budget, but we do want to hear about the budget. So, and we have been busy with some other things, and we'll get there, and we
Yeah,
appreciate your time.
no question, we're all busy. Right now,
Yeah.
I think I have 4 blocks next to each other scheduled. So, and actually, my calendar has gotten a little more reasonable, but it still is there's double booking and triple booking on a
I
regular
would like to know when the calendar gets more reasonable. Hasn't happened here yet, so
Yeah.
we'll see what.
Yeah.
Questions for Corey? Go ahead, Senator Hardy.
Sorry, had to unmute myself. Well, Commissioner, it's nice to meet you. I think actually this is the first time I've ever met you. So it's a little, a lot to absorb, what you just went over. And I don't have a specific question, just wanted to say hello and nice to meet you, and looking forward to learning more about your work. And it would be great. You mentioned that you sent us something.
We have an
When did you
annual
do that?
we have an annual report that I would imagine Nellie has a copy of to distribute to you. You are also, if you request a hard copy, we will produce one and send it to you.
I don't need a hard copy. It would just be great to get it again. As you can imagine, I'm sure your inbox is insane. Ours are completely insane. So if it would be great to get that again. And
Sure.
and I would love to hear more about your budget request when you come in. But I think that there's a lot of opportunity right now with the American Rescue Plan and all the reform that's happening or potentially happening at the federal level. So I would love to talk more with you about what the opportunities at the state level are to move our system along, and whether or not your division and team is ready to do that, and what we can do to help you get ready for that.
Thank you.
So, and yes, so the report we just got, so it will be posted. Nellie will be posting it soon, and absolutely, DEVA is integral to all of our conversations on moving healthcare reform ahead. It gets to be an interesting conversation.
Yeah, and just to organize that too, we are, as I said, the backbone of Medicaid. We're one of the payers, and healthcare reform cuts across all payers. As as I said, we've been working on this for several years, but we've seen ourselves as a catalyst or a leader, right? So something that will not be familiar to you is that, I guess you'll probably hear it from Ina next week if she's talking about healthcare reform, but we have really been a leader in terms of how we structure our relationship with an ACO, and how that relationship could be structured in a way that we could get a more integrated healthcare system. So, Medicare's system of an ACO relationship is different than the Medicaid one, and the Medicaid and our current relationship appears to be a better way to get to the goal of predictability in payment, reducing the fee-for-service, sort of do more, get more kind of it's not mentality, but incentives. And so, we have engaged in that. We're leaders, but because we're leaders in the sense that we're executing on it and giving sort of like testing the water more than we are just telling everyone what to do. So.
Senator Hooker has a question.
Thank you, Commissioner. I'm really pleased to hear that Vermont is being positioned, that we're leading on the leading edge of things that may be coming out of the federal government, so that we're ready to take up whatever happens there. A couple of questions, and I'm sure this is in your report, but how many people are there in your division that are doing all this work?
Yeah. We have about 350 people right now in positions. About 120 or so are in the in that eligibility and enrollment unit. And we have about 20 functional units that range from a business office to a grants and contracts team to a program integrity team. We have a policy team. We have a clinical grouping of units. So we have a pharmacy unit. We have a clinical review unit. Quality unit. So it's about 350. I think we have 370 or so positions available to us, but the hiring freeze has made it, we're not able to have all the people that we have in our stable necessarily.
Okay, so obviously pretty complex. And my last question is, could you give us a sheet of all the acronyms, because I'm not familiar with all of the alphabet.
Yeah, well, you can tell that even the most simplest ones give me trouble sometimes. So I understand that. And yeah, we have that. We have an acronym sheet.
Thank you.
Okay, and if you give it to us, we will then we'll have ourselves a little quiz. See how we do.
Well, good luck. Let me. It may be in the book, but anyway, it may be in.
So no, Nellie did post the report that you sent in, so now we've got it. And we can go through it. Yeah, I think as we go forward, it will be important for everyone to understand the relationship between Medicaid, Medicare, private insurance, the alignment or lack thereof in terms of trying to build policy for our healthcare reform. So there's a lot.
Yeah, and I would characterize it this way. I mean, the healthcare system evolved over several decades. I mean, the current one we have, right, it's 6-7 decades without any plan whatsoever. And we are trying to, through I think the old saying goes, the coalition of the willing, to, incentivize alignment. And it's much easier to tell people what to do than it is to create an environment that is better for both sides. I mean, there's some give and take, obviously, but that's our goal, is to create an environment that makes sense, that benefits the state as far as expenditures, but more importantly, improves quality for the Vermonters that use it. And of course, our concern is our membership, right? What I think many would call Vermont's more vulnerable, if not most vulnerable.
Okay. Any other questions? I want to say thank you for your time, and we will consider your confirmation next week, and then take our recommendation to the full Senate. So, and we look forward to working with you as we have in the past. So thank you very much.
Thank you,
Senator. It's good to see you.
Thank you. Good to meet all.
All right. Okay. Thanks. All right, committee, we're looking good. Their H-117 is on the calendar. We can act on it today or not. I'm going to have to leave the committee. I have to talk with the pro tem before we're on the floor. But in H-117, that's our flexibility, regulatory flexibility bill. The House took out the little section on immunizations. Apparently there were some concerns there. I don't know all the concerns, but frankly, that section of the bill will not, it's not COVID related necessarily. It is important, I think, to the Department of Health and to providers, but we can come back to that another time. My inclination is to concur with the proposal from the House, but I'm open if you want to negotiate that immunization section.
Senator Lyons, did they not, the chair didn't give you any indication as to why they took that out? It was just,
Yeah, he did, but I haven't had a chance to fully discuss it with him, so I can't,
Okay.
I know I can't tell you everything.
I personally am fine with concurring, and if we need to come back to that section and add it to some other bill, we probably will have an opportunity to do so once we hear what the House's concerns were. I know that there's a lot of concern in the field that we get this bill out and to the governor as soon as possible. And so I guess I'd rather do that than hold it up for this section.
Okay. Senator Hooker?
I agree. I have to look at the section to see even, I don't remember what it said about immunization, so I need
It
to.
was that the Department of Health could send immunization data from the registry to the Vermont Health Information
Exchange.
Network.
Question about privacy, maybe, I don't know.
No, there's nothing about, that's all regulated through HIPAA, so
Sure.
it's not, it's a matter of allowing for providers to access immunization records for their patients. And if it's not on the Vital Network, then it becomes more difficult to access it.
All right, well, I'm fine with concurring for now and checking into this
Yeah.
later.
Senator Terenzini?
Yeah, I'm fine, Senator Lyons. However we want to proceed, it's important that we get it done, it sounds like, so.
Yeah, I think so. So I'm going to go through the bill one more time. If I see anything that is a cause for concern, and I'd ask you to do the same, let me know before we get to it on the calendar.
Are we gonna try to do it today to get it out?
I was going to try to do that today, yeah.
Yeah,
And if we can't, we're going to do it Tuesday.
okay. Yeah, I
All
think
right.
it'd be good to do today.
Yeah. All right. Anything else? And I mentioned the other bills that we should be seeing from the House, and we'll talk about that on Tuesday. Okay, Nellie,